Hello, thank you again for joining us today for a discussion with Kara Robinson, Education Coordinator at Trinity Health Oakland, to hear about how their ICUs transition from a conventional dialysis program to a PIRRT and sequential therapy program with the Tablo Hemodialysis System, unlocked nursing efficiencies, and helped support patient care. Just a reminder, you can pop questions in the Q&A throughout today's webinar, and we'll have a live Q&A at the end. And over to you, Amanda.
Thanks, Mike. And good afternoon, everyone. Thank you for jumping on. I am really excited to spend this time with you so that we can all learn a little bit more about Tablo in the ICU. The way we're going to do that today is we're going to explore how one hospital in Michigan has transformed the way they care for patients through technology, innovation, and disrupting the way we've always done it. But some of you are going to hear some things that may shock you today, especially if you've only worked with conventional ICU dialysis devices and the care models in ICUs that it requires. For those of you, I'm going to ask you to hang with me and keep your mind open. At the very least, I think it's important for us all to consider that back in Egyptian days, hand washing was heresy. And all of this just survived a pandemic where hand washing was a key to infection prevention 4,000 years later. My goodness, our patients don't have that much time. So I am really excited to share a real story of innovation through Kara Robinson's experience converting her Tablo or to her ICUs to Tablo in May of 2020. Kara Robinson is the change ninja you see on your screen here, who has been instrumental in the implementation and success of the ICU program at her hospital. I have been the personal beneficiary of her partnership, and I'm very grateful she has agreed to share her story and experiences with all of you today. Kara, seriously, thank you. I am just so happy that you're here. I would like us to start by setting the stage, if you would, and just giving the audience an overview of your hospital and your ICU, just so we know what we're working with.
Sure. Thanks, Amanda. That was really kind. I appreciate that. Trinity Health Oakland is a level 2 trauma center. It has 497 beds, also a comprehensive stroke center, cardiac, OB/GYN, and multiple other patient populations. So we have a wide diversity of patients. And currently I'm the education coordinator, as mentioned, for the ICU and the hemodialysis there.
So Kara, how many ICU beds and how many ICU units have you implemented Tablo into at your hospital?
We have 2 separate ICUs. One's a general ICU and the other is a cardiac ICU. Altogether, there are 44 beds and about 120 nurses.
Okay, great. So team, no small potatoes here. Kara has sick patients and a diverse population. And so I think we should start at the very beginning of your story, Kara, with Tablo. And can you just give everyone an idea of generally what was the current state before you implemented, and why did your facility choose Tablo?
Sure. So prior, we were a outsourced provider dialysis, and our ICU dialysis, our CRT, was provided by Next Stage System. And so our next stage was end of life. And as I mentioned, our dialysis provider was outsourced and they didn't have the capability to provide SLED or CRT. And in addition to that, their staffing also limited our options and often delayed our treatments because of the other needs needed throughout the hospital. So we identified that there were some operational inefficiencies, and we saw that Tablo could meet those needs and even fill in the additional gaps that we found. So that's why we decided to go with Tablo.
So when your team, I know your team was a big part of the decision, when you were looking at technology and you were looking at making the change, what was the most important to you and to the team?
Well, patient needs obviously are the main priority, right? You have critical patients in the ICU, the super sick patients. So meeting the needs of the patients and what they needed was definitely the top priority. But we also wanted to look at, functionality. Is it easy to use? Is it reliable? And Tablo seemed to provide that. In addition, they offered the Wi-Fi connectivity and the data that was available through monitoring, which was really an attractive piece. And then the cost analysis that we were able to do and find that was beneficial was not a priority, but definitely a benefit. And then we didn't even realize at the time, but the flexibility that Tablo offered would potentially lead to our decreased workload and even improve patient outcomes and decrease length of stay. So that was a huge bonus that we found.
So I'm just going to reiterate to the team on the call that Kara went live in May of 2020. And so in Detroit, we got hit really hard during that time with the first peak of COVID. And so, Kara, I can only imagine what the initial reaction your team had to the technology, but also to the fact that they were going to have to totally change the way they did ICU dialysis. How did that go?
So the nurses were definitely hesitant. I mean, Tablo was a completely foreign concept to them. They were used to the CRRT type philosophy. And so having that was something totally foreign. All they knew was the CRRT. Tablo, they didn't understand it. They didn't understand the functionality or even the ability that it had. And so they going from hourly calculations to not having to do that potentially, they were really worried, is this going to be safe for our patients? Is it going to meet the need of the really sick patients, especially during COVID? At the time we had really high acuity. So there were definitely hesitations and concerns.
Yeah, and that's absolutely understood. I remember those days. That was back when we had been taping the gaps in the walls and in the doorways because we really didn't even know what was in front of us. So considering that situation, how long did it take your team to become comfortable with Tablo in the ICU with those really sick patients?
Well, like you mentioned, we launched in May of 2020, which was the peak of COVID. And so our training was a little expedited. We had to do hands-on training, obviously, for all of our staff because we were training all of our ICU nurses because of the high number and the high acuity of patients and treatments that were needed. And we were dealing with nursing shortages too. So it took several months for us to get our training, but we were able to do that with a combination of different training options.
Yeah, so the picture you're painting for me and what I'm remembering gives me a little PTSD, and I'm sure some of the other nurses and healthcare providers on the call. So after all of this time, you have a whole lot of experience. Looking back, how do you think you did it? And how do you think you came out with a successful program? What led to you or to you being able to get through it and come out successful?
Yeah, so the COVID kind of forced our hand, right? We had the high spike in numbers, so we had to train quickly, and we also learned quickly because of that. So we had about 100 nurses. We went live within 60 days of our launch, and so we were moving pretty fast. But with all of that, we recognized early on that we needed to actually develop some sort of Tablo leadership or ownership, and that also included having a physician champion. So after those about 6 months and getting experience and doing a lot of those different things in the advanced training, we were able to use that philosophy and provide that additional support for the nurses internally, which really helped identify learning gaps and needs and identify different things that we could really take our time and attention to help accelerate that learning and help with that RN experience.
Yeah, and I will give you hats off to you, Kara, and thank you for all of the efforts during that time because you were instrumental in that. It really makes a big difference hearing it from a peer that, the device did this or gave you this alarm because of this patient issue or because you didn't do this right or because there's something going on with the water pressure instead of the absence of any information and just seeing an alarm and not knowing how to troubleshoot it. So you were huge there for the whole team. So now that we've talked about nursing, and how we kind of brought them along during that initial learning curve. How about the physicians? What was the biggest concerns they had? And then how did you manage their expectations and their clinical objections?
Well, I think, the physicians had similar concerns to the nurses. They were worried that those really sick patients, would be able to tolerate the Tablo since it wasn't a CRRT type treatment. They were concerned that having a 12-hour treatment wouldn't be enough or gentle enough for the patients. And then on the opposite end of that, they were resistant to the different settings within Tablo and whether or not a patient could potentially tolerate those settings. When we were looking at DFR and considering it being, aggressive enough or not aggressive enough for what the patient needs were. But actually, they identified over time that based on the patient's needs, being able to adjust those were actually more efficient, and patient outcomes and labs were showing that those 12-hour treatments or even less were just as beneficial for the treatment or for the progress of the patient.
So I have to ask you, while I have you on the call and all of these people as my witness, Kara, since you've implemented Tablo in May of 2020 and have only used Tablo in your ICU since that time, has there ever been a situation where a patient had to be transferred out because you couldn't give them the care they needed because they were too sick and the renal replacement therapy that they needed, you didn't have because you only had Tablo? Was there ever a situation where you didn't feel like you were giving your patient the care they deserved?
No, actually, we found that our 12-hour treatments were more than enough for the patient. And we even actually found that sometimes we didn't even need a full 12-hour treatment. So we were able to provide the needs of our patients and even meet and exceed those needs for those patients. So it was really nice to see that.
Again, thank you for being a trailblazer and for bringing the team along to be able to realize that. So you and your team have done a ton of work, and everyone who's a nurse on this call knows that that is the heart and soul. I'm a little bit biased, but I'll say it on screen in front of all of you. So your team has done a ton of work. You specifically and the ICU, charge nurses and support staff in working with Tablo into your program to really take advantage of the operational advantages with being able to have shorter treatments and being able to have an easier setup. Can you just share some of the things that you have seen from a patient benefit perspective, a nurse benefit perspective, and your whole unit? How do you benefit that? How are you getting time back with your new way of performing dialysis in the ICU?
Yeah, so we definitely saw a lot of benefits. So if we're looking at patient benefits, if you think previously with the CRT, the continuous treatments, you had delayed procedures, delayed imaging, different tests. You couldn't progress the patient care. Early mobility is a really big thing in the ICU. So we weren't able to do that with the previous system. But with Tablo, with those 12-hour treatments or even shorter, we could actually have those things included throughout the day for the patient. And so we could not only do the Tablo treatment, but we could also include the testing, the imaging, the therapy, the mobility, and those different things. So we were seeing progression in the patient care a lot better than we were previously. And same reason with those being able to do all of those things, we saw nurse benefits out of that. The nurses were able to provide those things, prioritize, schedule appropriately, and get those things so there weren't the delays and it wasn't adding to the frustration in the nursing workflow. And so being able to meet those needs and provide all of those things for the patients was definitely a success. And then also we're seeing that the workflow just in general of the unit and the ICU was benefiting because we were able to plan staffing better with it, meet the needs of not only the staffing and the patient flow, but we were able to better plan for the bed flow of the unit and what the plan and outcome would be day to day instead of worrying, how our CRT or when, if ever, the CRT was going to be done.
Yeah, I definitely find that to be true with conventional therapies in the ICU. The nurses really wait for that CRT to tell it when it's done. And with Tablo, you have really leveraged the ability to schedule treatments and know this is when it's going to start, this is when it's going to end, and I'm going to do all the things for my patient in the time around that. So thank you for highlighting that for everyone. I would like to just share, I've done a little data dig, and because Tablo holds all of the treatment data in the background for us, I was able to pull up data since launch for Trinity Health Oakland in May 2020. And since then, their ICU has done almost 1,500 treatments since their launch. And when we look at the duration of those treatments, we see that about 550 of those are less than 5 hours. And so the team at Trinity has actually, the ICU team has taken over those 3 to 4 hour IHD treatments as long as the patient has a catheter. And Kara can talk about the benefits that they have found with that or how they've worked that into their program. But not even looking at those 550 treatments, just looking at the 950 treatments that they've done since 2020 that are over 5 hours. So Kara, is it safe to say all of those patients would have been on conventional CRT? They would have been on 24-hour therapy continuously. Is that safe to say?
Oh, definitely.
Because it was
Definitely.
either one or the other, right? There was no in between. And so now if we look at those 950 treatments, of those, the average treatment time is actually 8 hours. So although Kara and her team, if a really unstable patient needs dialysis, they will start them at a 12-hour therapy, right? Because that is that's the longest Kara's machines go because they're from back in the day, the OGs. And so if the patient is not getting an intermittent hemodialysis treatment, a short treatment, they're getting about 8 hours. And so what that does when we look at over the span of time and the impact that's had is that means that Kara and her team have saved 633 days of therapy for their patients, but also for their nursing staff, because that 8 hours of treatment frees up a one-to-one nurse for the remainder of the day. And so if we look at those 633 days of therapy saved, that means Kara and her team have saved themselves 1,266 shifts, because those shifts did not require a one-to-one nurse-patient ratio in regards to dialysis. And so the impact that that has certainly plays into cost savings and efficiencies, but at the end of the day, a nursing shortage is what we're faced with right now. And that is the number one thing I hear from my peers and from executives across the country. And so to be able to make an impact like that with ICU nurse staffing has been tremendous to watch. So congratulations, Kara, for making a big difference there.
Yeah, we've definitely seen a huge advantage and benefit in that. So it's thank you for sharing that.
So besides that, let's talk about one more thing that can be controversial, but also you have leveraged to work in your favor, and that is the total ultrafiltration. And so anyone who knows Tablo knows that Tablo calculates fluid removal for patients based on a total ultrafiltration goal. So unlike conventional CRT machines, you're telling it, take off this much per hour. Tablo, you say, take this much off for the entire treatment, and then the doctor decides how long that treatment's going to be. Tablo does the background math and then spits out an hourly ultrafiltration goal, just like we're used to on conventional devices, but really does fluid removal very differently. So can you set the stage for those who might not even know about CRT and the current state of what is required to maintain? Like, how does a nurse manage a CRT machine when it comes to the ultrafiltration or the fluid removal of the patient?
So with CRT, it's based on an hourly calculation. So the physician orders what the hourly removal goal is, but that is based on a net. So they have to remove that in addition to the net balance of the patient's fluid. So each hour, the nurse has to calculate what the hourly intake is, what the hourly output is, what that net balance is, and then add that fluid removal goal to what that balance is, and then program that in the machine and do that every hour, and then document that every hour as well. So CRT definitely is very tasky and can be very interfering with the nurse's workflow for the patient, because it can consume a lot of their time.
So let's look the other way. And can you tell me how your nurses and your doctors manage total UF or ultrafiltration fluid removal for their patients on Tablo?
So the physician still comes in, evaluates the patient, looks at the patient and what the patient condition is, what their needs are, if they, need fluid removal, how much they need, how much they would be able to tolerate. And the physician calculates that, but instead of as an hourly goal, they're going to calculate it as a total for the length of the treatment. So there's just one value that has to be entered, which is really nice. So the RN only has to enter in that total fluid removal goal or total UF in the Tablo when they're doing the setup. And there's no hourly calculations. There's no hourly documentation of the fluid removal. They just document the Tablo pressures and numbers of the treatment throughout the length of the treatment. So they've removed that hourly task from the nurses completely. There's still the ability to troubleshoot and intervene for the patient if needed and adjust the treatments. But having that hourly calculation removed allows the nurse more time back for the patient and meet the needs of the patient. And they only document the total UF at the end of the treatment in the flow sheets in the medical record. So it's definitely been less math, which means there's less errors, less chance of confusion. And the nurses and the physicians both recognize that this was a more safe and effective way to practice.
So for those of you who I warned, you may hear some things that shock you. This may be one of the things. And Kara, I'm just going to ask again, so it's abundantly clear. Have you experienced a situation where this was harmful to patients or not the right thing to do?
No, because like I said, if you identify that your patient has changes and you need to adjust the treatment, you have those options built in either in the order set or with a phone call with the physician, and you can still make those adjustments throughout the length of the treatment to meet the needs of the patient. So it's really nice that Tablo allows that, but also does all of that math for you so that the nurse can give more time back to the patient.
Awesome. So how did you manage that change with the team? Because that is one of the things that really blows a lot of people's minds, and is tough to conceptualize how the way we've always done it is very specific and intensive and time sensitive, quite frankly. How did you manage that change to bring people with you? What made it easier?
So we definitely wanted to be as safe as possible and efficient as possible. So the nurses and the physicians looked at the build of Tablo and looked at our medical record system. We were using Epic and actually built flow sheets to match not only the functionality, but the wording and the steps that are built into the Tablo system. And it definitely helped with the nurses being able to flow more efficiently with their workflow. And so it just made it that much easier. And then we also worked with pharmacy to build order sets that matched the information that was in Tablo, how the prescription would be written, and it met the needs of how to program that. So the nurses just used the order and went straight from the order to Tablo, and were able to go straight down the line and follow the order and program the treatment as ordered. So definitely a benefit there.
I think it also speaks, this example speaks to how important it is to really have everyone speaking the same language, right? To have buy-in from physicians and nursing who both understand how Tablo works, and then bringing in pharmacy, who is an integral part of any patient's care in the intensive care unit. And so on the topic of pharmacists, I hope we have some on the call today, but would love to talk to you about anticoagulation and your journey with your previous situation as opposed to your current, as it relates to keeping patients from clotting the system so they can get the therapy they need.
Yeah, so previously with our CRRT system, as many probably know, the ICU patients, the more critically ill they are, the more likely they're to clot. So we were using different ways to anticoagulate during treatments, and one of those was citrate. Citrate was very tasky. It was a lot of work for the nurses, a lot of time spent doing those labs and interventions hourly, in addition to just the calculations, not to mention the adverse side effects that it potentially could cause the patients. And so when we chose to move forward with Tablo, we chose to eliminate citrate completely. We do have heparin if needed in those instances, but our gold standard is to utilize scheduled saline flushes. So it's a standard now that all of our treatments actually have the saline flushes scheduled in throughout the treatments. And that's been a huge benefit.
Any advice for those current customers or customers who are starting to implement? What would you recommend for a saline flush order? Like what is your typical, what's your go-to?
We have found that 100 mLs seems to be the perfect volume to flush fully and maintain the life of the treatment in the system. So we do 100 mLs either every half hour or hour at the max.
Okay. Okay, so shifting back to staffing, can you share with the group some of the creative things you've done with staffing and that you've been able to do to give time back, to make it more efficient, and to make sure that everybody has a reasonable workload and patients stay safe?
Yeah. So like I mentioned earlier, all of our ICURNs are trained to provide treatments, so they can run a treatment. So if we need to flex staffing, we can. They are one-to-one for the duration of the treatment. So a lot of times, as Amanda mentioned, our treatments aren't necessarily 12 hours. So the shorter treatments, we're able to flex staffing so that we can free up a nurse. We also have an alternate shift, an 11 to 11, so they can come in, they can cover those treatments, because we usually know by morning what treatments we have and how many. And so a lot of those staffing flexings that we've done has helped to decrease the delay in treatments, and also allows the nurses to accommodate the needs of the patient. So that's been a huge benefit in helping timely with those treatments, decreasing length of stay, and just benefit the patient. And then we also even offer the nurses the opportunity, if we're short, to come in and pick up just for a Tablo treatment. So they can come in, they do the Tablo treatment, and they leave. And so that's a huge opportunity for nurse satisfaction, because they can pick up extra time and extra pay without actually being committed to a full 12-hour shift. So that was a huge benefit for staff and flexing that way. We also created a Tablo tech or an equipment tech role who is responsible for the routine maintenance of the machines, the ordering, the supplies, but we also were able to justify that by saying we're going to make this role responsible for all of our equipment in the ICU and supplies and ordering and work orders and that type of thing. So having that just a little additional piece where they could dedicate part of their time to the daily maintenance of the Tablo devices has really helped make us more efficient with our treatments and prolong the life of the machines. And it helps decrease delays in that aspect too.
Yeah, so the Tablo techs make sure the machines are ready, but also that when the nurse needs an A-line cable, it's where it's supposed to be. So I've watched the transition and it's been really helpful. And in fact, it's been so successful that Kara got a second head approved to have full week coverage. So her team is well covered and those Tablos are really well cared for. So nice work there. Okay, so let's switch over back to clinical and talk about, so you were a super user for the previous ICU renal replacement program in your ICUs, and now are the super user Tablo extraordinaire, I like to call you, and in SLED and PIRRT. So what has the change clinically been? What have you seen between previous state and current state?
Well, I think having the flexibility that Tablo offers, we've seen less changes in our patients. Our patients have been able to progress more smoothly, less crashing when they transition to IHDs. So a lot of times we'll start our really sick acute patients out with 12-hour treatments, and we'll slowly progress them down to shorter treatments so that we can get them more safely ready for IHD if that's the need for the patient. And so that helps also decrease their length of stay because we're not having those long periods of CRRT, and we can actually progress them as they're tolerated. And also, like mentioned earlier, we can fit in those other things that are needed for the progression of care for the patients. Early mobility, like I mentioned, is really big in the ICU. So being able to just fit that in, even just a little bit, is a huge benefit. And so having that more control over the plan of care of the patient has really, really been good. And so once we saw all of those things coming together, we identified early on that we didn't need to change to a 24-hour treatment. So we do 12 hours or less for our patients, and the nephrologists have totally been on board with that.
Yeah, that's the real secret. Being able to not take anything away from patients, but to give them more time to get the other things they need done. So let's talk about outcomes. Some of the really important outcomes for ICUs, for hospitals, for hospital administrators, for patients, really is length of stay. So can you tell us about your outcomes as it relates to length of stay?
Yeah, so I mean, we didn't track it previously, but just seeing that we have a Tablo patient who were able to provide mobility and, early mobility and those other things, it's obvious that we're already ahead of the game because we're not delaying it like we would with CRRT. So we're providing those treatments early on, which means that we're progressing their care and eventually decreasing their length of stay. One of the biggest populations that we see that in is our cardiac surgery patients, who the goal is to ambulate 3 times a day. And so with those shorter treatments, if they're needed, we can actually meet those needs. And it's been a huge success in progressing the care of those patients. And, even our staffing costs have decreased because, like you mentioned, having those shorter treatments, we don't need the continuous treatments. So our one-to-one time related to providing dialysis has significantly decreased. Even though it wasn't tracked previously, we know that it has definitely helped in the cost savings there with the unit and even the staffing experience overall. And then not to mention just the cost savings that we have with the Tablo system. I don't know the specifics on that, but I know that we've saved significantly on that.
Oh, I do. I know, and I'll share. Per our initial ROI and really what we know that the team was paying for CRRT supplies alone. So just thinking about the disposables, the cartridge, the bags, Kira's team has confirmed that it is like a 90% cost savings in supplies alone. And that is because the cartridge is less expensive. The bag dialysate completely goes away, and that is a huge part of a chunk of what that disposable cost is. When we are changing a bag 12 to 15 times a day, and those bags cost up to $50 a day, it adds up really quickly. Not to mention, that's if one cartridge lasts you one day. And we all know on this call that sometimes, whether the patient's septic and is just clotting and clogging, or there are other issues going on, Many times those cartridges don't even make it 24 hours. So it is, again, a 90% cost savings in her ICU. And that is for almost 1,000 treatments in the past 4 years. So definitely cost savings there. And that's just the hard cost, right? The soft cost that Kara highlighted, the staffing decreases of 1-to-1, the ability to flex and float and to provide those shorter treatments for those patients who are ready to go in the morning and need dialysis, that short treatment before they get discharged to the floor. There's less delays there. And so if we think about what that could mean for length of stay and the overall cost of care to take care of a dialysis patient and get them to health significantly decreases. So Kara, I am going to ask you one more question, but I'm just going to let the team on the call know now is a great time to submit your questions for Kara. Give it to her. She can handle it. And I'm just going to end with one more question that I really would like everyone to walk away with, which is, what are the best practices that made your program a success? Like if you were going to do this again, or you were talking to past you and you're a future you, and you're like, past Kara, this is what I would do if I wanted to set up a successful Tablo program in my ICU. What were those things, or what are those things?
Well, just like anything, when you're creating something, you want to be able to dedicate the time and attention that it needs to make it, create it, help it grow and be successful. So having someone who owns the program, I think, is essential. We learned early on that that piece was really important. So having someone who owns the program, can be the device expert, helps with training, organizing day-to-day flow, that type of thing is really important. And then having dedicated team members who can dedicate their time to the supplies, the maintenance, those ordering pieces to help your program stay up and running is really important too. And then obviously physician champion is a huge piece, because you need a physician obviously who knows and understands Tablo, but can also help with their colleagues, the other physicians, and can speak to the Tablo capabilities. And then just like any program, right, you have ongoing learning, continuous training, advanced training even, following up, learning, evaluating things, making adjustments. And so doing that is important, but having a group of super users who can help with that, help continue to teach, be precept, provide those learnings, even real-time learnings when needed at the bedside is really important. And then for evaluating your program, having huddles and lunches so that you can review needs, learning opportunities, and even share updates, from outset. So it's very valuable. And not having access to that before and having it now, we've seen our program be a lot more successful because of that. And so it's really important to have those things, but then also know that change is going to come, and be prepared for change, because after you go live, you're going to see what works, what doesn't. So just know that you want to continuously monitor your program and make adjustments as needed, because that's what's going to build your program. And then obviously, when it comes to having a successful Tablo treatment program, you need the machines to be able to be functioning. So having a service program in place and maintaining the life of the machines is also essential. So those would be my big pieces that would make a successful program.
Yeah, I think you're spot on those. And I'm really excited to know that you hit those pretty early in your journey, right? So that 6-month mark, when it felt really good, it's because by then Kara and the team had already implemented a lot of those best practices and continue to do so today. So they're well vetted if you'd like to use them for your own. Okay, well, there were a couple of questions that were sent in before the presentation. So Kara, if it's okay with you, I will start there. There's a couple I have here in the hopper. So the first one is around nursing communication. How did nurses communicate across the 24-hour time span to ensure they were meeting ordered goals?
So just like any nursing practice, right, you're going to continue to make sure that you have that communication, that handoff from nurse to nurse, but also from provider to nurse, so that everyone's on the same page. You have the right information, the correct information, and just make sure that you're meeting the needs, and continuously reviewing the orders and the needs of the patient is essential, because as the patient progresses, there might need to be changes. And so just having that communication and documentation even is important, just like it would be for anything else.
Awesome. Okay, next. How important, this one's around clearance and our flow rates. So how important is clearance when doing patients in the ICU? Some run blood flow rates of 400 when the BUN or creatinine is low, question mark. I think they're wondering what kind of settings you're using for clearance.
Yeah, so obviously clearance is important for, the patients, but a lot of times in the ICU, those higher acuity patients, more critical patients, we're going to run a little bit slower and gentler. So we don't see that 400 rate, but as the patient changes and it progresses, they may adjust to that. And we even found that even at a slower rate, we still see the lab values and the clearance that the patient needs to continue to progress. It just may not be at a typical rate that you would for like an IHD type setting for a patient.
Yeah, and so for you, Kara, and your team, is solute clearance the priority typically? Is that like the most important thing, or is it fluid management?
We occasionally have those patients that come in that need the clearance, but a majority of our patients also have fluid management as a priority. And so it's a fine balancing act of meeting the needs of the fluid management as well. And so sometimes that will be the priority over the flow rate. So they'll focus on that more so.
Right. So you have the ability to like treat like a toxicity patient who needs something quick, but you also have the ability to gently take fluid off a patient who would not tolerate it fast.
Right.
And everything in the middle. Is that what I'm hearing?
Yes.
Okay, good. Thank you. Okay, I've got one more from the before the meeting, and that is we get alarms and errors from time to time. Did Tablo upgrade their system to prevent all of these?
Well, I think, there's a learning curve with any new program and new system. So we adjust it as needed. And, having someone who knows the system, the program can help navigate those things and meet the needs, whether it is the device or the user. And so as you get better and grow, the whole program will grow.
So today you're happy with the reliability of your Tablo devices when you need them, they're available. And have you gotten different machines at any point?
We still have the 4 original machines that we started with, and they are functioning very well. If there are an occasional service that's needed, it's done quickly and it's met and turned over and ready to go within a day. So, having someone who can be involved on the daily care of those patients really helps with that. And a lot of times they can identify that, maybe it's not even a device issue. So they can help progress that even more.
Yeah, shout out to the
program
Tablo techs for sure. They make a
Mhm.
difference there. Okay, so those were all the ones that we had gotten before, but I'm just that looks like there's one more that came through in the chat, and that is how do you manage patients with high hourly intake volumes on pressors that end up with high UF goals of 750 per hour? So high volume in, and how do you manage those patients?
So typically, our nephrologists are the ones that own our Tablo program, and they are in close communication with the patients. So if they know going into the treatment that the patient's on high pressor needs and high volumes, then our ultrafiltration goal is actually going to be set lower, and we're going to progress up through the treatments to the ultimate goal, because they know obviously that if the goal is too high, we're going to have to go up on pressors, give fluid back, and we're just going to totally defeat the purpose of removing the fluid. So they start really gentle. It might be a 12-hour treatment. It might be a slower or even less treatment, but the fluid removal is usually less than that because of the pressor needs of the patient. If the patient has changes during the treatment and you're having to go up on pressors and stuff, our nurses will notify, and then our nephrologists will modify the UF goal as needed for the patient as tolerated.
Yeah, I think one thing that I would like to point out is one of the secrets of success here is that Kara has educated her team to be a dialysis nurse. So those ICU nurses are also dialysis nurses. Tablo helps, but Kara is instrumental in making sure they understand the why behind what we are doing for the patient, so that when something changes, they can be proactive, reactive, but they know why. They know what's going on. Is this a hemodynamic issue? Is this a fluid issue? Is this something else going on with the patient? They have the ability to troubleshoot that, which I don't want to speak for you, Kara, but typically what we see in conventional renal replacement therapy programs in ICUs is the nurse is really looking at numbers and hoping that nothing bad happens during that day, during that shift, right? They're just hoping they can make it through.
Yeah, it is. It's about knowing the patients well and having that communication with a nephrologist and really understanding what the need of the patient is. So very important to have a strong program and strong nurses, and also that relationship with the providers as well.
Yeah. One more question from the audience. Which shift do they routinely perform these SLED or PIRRT treatments? Is there a specific shift that you focus on?
It's usually on day shift, but both of our shifts are trained, and sometimes we'll even modify when those treatments are provided based on the needs of the patient. So if we know going in that the patient has a lot of treatments, testing, imaging, any of those things during the day, and we have the staffing on night shift to provide the treatment, they'll do that and provide the treatment overnight.
Yeah, that's a good one to highlight. So does your charge nurse typically play the shell game a little bit easier now, would you say, when it comes to dialysis?
Yeah. Definitely so. Now that we're seeing that we're doing shorter treatments, it's easier to plan the day or even the shift for the patients, knowing, okay, we're going to have, X amount of 4-hour treatments, we're going to have a 6-hour treatment, or we might have a 12-hour treatment. So they'll work with that, what the staffing is, and also how the nephrologist wants to prioritize. If we have multiple treatments, they'll ask the nephrologist, who do you want to prioritize? And then that'll let them know too, like if we need to put one on night shift, we can do that as well. And so they just really keeping that communication line open, and also working with the needs of the patient and the needs of the staffing.
I love that. Okay, so here's a question that I definitely want to address because I probably did not speak well to this. So the question is, how did you train nurses to complete cannulation? That seems to be a big hurdle for our ICU nurses. So I'll let you answer that, but please make it emphatic like I would.
So when we developed our program, our nurse leadership, we met with the nephrologist and really said, what do you see you want out of this Tablo program? And same thing, they asked us, what do the nurses want out of this Tablo program? And after conversation going back and forth, we realized that probably most safest for both the nurses and the patients was our nurses were only going to provide treatments to the ICU patients that had temporary or permanent catheters. So our nurses do not provide treatments for those that have fistulas. And I can see where the concern is with that, because there are the chronic dialysis patients that come into the ICU. But oftentimes when those patients are coming into the ICU, they are so sick and hemodynamically unstable that they end up getting a catheter anyways. And our treatments are provided by our nurses in the ICU through that access. So they don't cannulate, but they do provide treatments through the catheters.
Thank you for clarifying that, because that's a big one.
Mm-hmm.
Okay, I have one last question. And this we may have covered, but I'm just going to let you give your favorite answer here. Okay, so you ready? Wild card. How is Tablo different from CRRT? And are you just using SLED?
So Tablo is different from CRRT because it is limited on the amount of time that you can run a treatment with the system. And CRRT is a continuous renal replacement therapy. Our Tablo system that we have only allows 12-hour treatments, so we can only run a max of a 12-hour treatment. But on the flip side of that, the Tablo system has so much flexibility that we can not only run a 12-hour treatment, but we could typically run a standard IHD treatment. So if the patient had progressed to the point where they were ready for a standard dialysis treatment, we could provide that for them with the Tablo system. So it has the full range of function to meet the needs of the patient. So we're not just using SLED, we're using the full range of the function of the Tablo system, which has definitely been a benefit for our patients.
Kira, I want to thank you again for being here with me today and all the days up to this webinar, for your leadership and for believing in us, believing in change, even from the beginning. I also owe a big shout out to the Outset team that implemented Kira's program and who continue to make sure that she and her team have everything they need to be successful no matter what time of day or night, because we don't sell a device. Kira, I think you would agree, we sell a team who is committed to a vision and a mission for something better. And I want to thank you for being navigating this amazing change in the way that patients receive care, and for being willing to share your story. And I want to thank all of you for joining and for being a part of providing better for our patients. So Kara, appreciate it. Everyone, have an awesome day. Thank you.
Thank you.